Welcome to Week 9 mini lecture. This is Dr. Lauterbach. This week we will look at the use of health informatics and health promotion, which is covered in Chapter 13 in the Friend and Whitehead text, followed by cultural humility in health promotion, which is covered in Chapter 14. The chapter provides an overview of health informatics discipline and scope of practice. The authors point out that health improvement priorities were set by the Healthy People Initiative, integral parts of implementation and success of Healthy People 2020 and 2030 included the use of informatics, and they describe the efforts to build and integrate the public health informatics infrastructure in conjunction with a nationwide health information network. The scope of practice and definition of health informatics includes the fact that it is both an interdisciplinary professional area of specialization and a scientific discipline that integrates the analytic sciences with a goal of managing and communicating data and information for the provision of healthcare. There are a wide range of analytic sciences used in the practice of informatics. Health informatics includes various health professions such as dentistry, medicine, and nursing, and covers areas of healthcare such as public health, acute and chronic health, and consumer health. Includes treatment of health problems, prevention, and promotion, as well as of general well-being. And then they go on to discuss a bit about the data to wisdom continuum. The data to wisdom continuum is an important construct for informatics. Data is not information. It's just data. Information is generated when knowledgeable people interpret data and give it meaning. The highest level is wisdom, which is only generated when information is applied with clinical judgment, compassion, and integrated into service. No current consensus exists about types of knowledge and how they should be classified. Mantzoukas and Jasper in 2008 used a secondary qualitative analysis to identify 5 types of knowledge guiding nursing care of hospitalized patients. Those 5 are personalized knowledge, practice knowledge used in therapeutic relationships, theoretical knowledge about relevant facts, procedural knowledge with ready-made answers for completing nursing care-related activities, culture knowledge comprising written and unwritten norms, rules, and values for care in the healthcare setting, and reflexive knowledge that is context-specific and developed through the synthesis of the other 4 types of knowledge through experience. LeChasser, Lazur, and Gilbert in 2011 used qualitative methods to research the mobilization of knowledge within the critical thinking process of nursing students. They identified 9 types of knowledge: intrapersonal, interpersonal, perceptual, moral, ethical, experiential, practical, scientific, contextual, and combinational constructive knowledge. Combinational constructive knowledge was described as a new type of knowledge created from a simultaneous combination of all types of knowledge in function of a specific situation. Wisdom is the appropriate use of knowledge in managing or solving human problems, including managing health conditions and promoting health. Wisdom requires synthesizing different types of knowledge and applying this synthesis to real-life situations. This diagram from the textbook shows the hierarchy of informatics-related literacies and their implications for health promotion. Digital health literacy incorporates each of these skills and abilities to access, understand, appraise, and communicate health information and engage with the demands of different health contexts to promote and maintain good health across the lifespan. Each of the literacies in this model focuses on a different aspect of literacy, but they overlap and they are interrelated. Weaknesses in any area affects competency in other areas, while improving knowledge and augmenting skills in the area facilitates improvement in other areas. This slide hopes to show how what we already have discussed about health promotion at various levels is integrated into using applications to promote health and well-being. Fitness tracking in mHealth apps, which are those that are found like on smartphones, are a common example of health promotion tools that improve general wellness. They are not focused on specific disease, but rather on an overall commitment to improving health and illness. The term mHealth is derived from the concept of mobile health as a general term in medical care to depict the use of mobile phones and other wireless technology. To be optimally effective, determinants of health must be considered in the design of health informatics software that is developed to promote health and control disease. So determinants of health is a factor that influences the organization of health promotion and disease prevention resources. Because nearly every characteristic of a society can have an impact on health of its citizens, the list could be unwieldy. The text lists several helpful tables of data resources for social determinants of health. Here is one of those tables. This one comes from the Institute of Medicine, and it shows ways to categorize and break out all the social determinants around specific areas of focus for health promotion. When thinking about health promotion in general and about information technology vehicles to promote health, you got to consider who is the client. And in this slide, it points out it can refer to a community, a group, a family, or an individual. The application to individuals reflects the varying relationships between the individual and the healthcare system. And there are considerations for data sources by community and county. And the principal source for health statistics for the United States is the National Center for Health Statistics. The client is the third factor that influences how promotion and prevention resources are organized. This slide I extracted from the text, and it talks about the principal source of health statistics in the United States is the NCHS, which is maintained by CDC and produces data on a wide range of health indicators. And here are some examples. The authors spend some time talking about the development and introduction of electronic health records, which really got off the ground in a major way starting in the 1980s and then further development through the 90s. But that development originally was kind of chaotic and not really very well organized. So the government got involved with some acts or laws about informatics for healthcare. The first big act was the High-Tech Act, which put some financial incentives for adoption by health systems, hospitals, and individual providers with a goal of achieving meaningful use and supporting some standards for the exchange of health information between various individual IT systems. And it had 5 pillars supporting the concept of meaningful use. And those were 1, to improve quality, safety, and efficiency and reduce health disparities. 2, engage patients and families in their health. 3, improve care coordination. 4, improve population and public health. And 5, ensure adequate privacy and security protection for personal health information. So when the government wanted to put some financial incentives to healthcare providers, be they systems or individuals, they had to determine how they would figure out if somebody was actually using an electronic health record in a meaningful way, or they were simply checking the box, but really none of the real benefits of EHRs were being realized. So they developed this concept of meaningful use. And meaningful use had 9 objectives. The first one was protection of the PHI. The second one was clinical decision support. So what do they mean by that? That is the capability EHRs have to guide clinicians toward evidence-based practice, clinical decision support. This has had a kind of a rocky start because providers were getting so many alerts and best practice advisories and different things that would pop up into their screen as they were trying to use the records. But that got refined over time. And now I think we are really quite dependent on clinical decision support. It does all kinds of different things. It will target you if you are, as a provider, prescribing something that's contraindicated in your patient based on, for example, allergies or drug-drug interactions. It also, though, will, and you kind of pull these things up, and I think all of you, although you're not prescribing yet, are using it in your work life. You know, I have a patient with hypertension, so I just can click on the hypertension guidelines from ACC and see how my, based on what's documented by my patient, how do we compare? Are they at target? Are they on the right meds? This sort of thing. Different systems have different levels of sophistication, but clinical decision support was really there to let the computer guide the clinician toward evidence-based practice and avoid safety pitfalls. One of those was computerized physician order entry, CPOE. That was just a revolutionary change. That people were no longer putting their pens to a piece of paper and writing out things. They had to go in, and it squeezed providers into having to practice in a way that was safer maybe than they'd been doing before. It took a lot of the variability that we saw in prescriptions, that clarified things, and it reduced medication errors simply by itself, as well as drug-drug interactions and allergies and other ADEs. So we have clinical decision support, CPOE, electronic prescribing, the health information exchange, meant that systems had to be able to talk to each other. There had to be enough standardization of the data that they could be moved across interfaces between different health information systems. Then it was patient-specific education, and that has not been as developed as far, but if you're working, say, in Epic, many of you probably are working in Epic or Cerner. If you're working in Epic, I only know Epic from a prescriber point of view. I have not ever used it as a staff nurse. But when I'm doing a wrap-up with a visit, I can click on patient education as one of the things I'm going to do to complete the visit, and the system will immediately suggest to me standardized patient education. I can review it, I can change it, I can edit it for the patient. There are free text boxes in there so I can customize it, but it drives me into the things that patients with the kinds of problems that are identified for them in the record need to have. And that really improves my teaching, because things come up that I hadn't even thought about, but that I agree are important. And then we have medication reconciliation. So it's interesting how much resistance people had about MedRec, and maybe still do today, because it was so time consuming and complicated. Well, step back a second. what's that like for a patient? If we can't figure out how to reconcile their meds, how in the world can they? I mean, it is time consuming. And I remember in the hospital where I worked when we had to implement medication reconciliation with every encounter. Physicians were screaming about the time it was taking, and they wanted non-prescribing nurses, not advanced practice nurses or PAs or anybody else. They just wanted nurses to go in and do the med rec, or pharmacists. Well, the pharmacists could do the med rec, but as nurses not in advanced practice roles, our ability to reconcile medicines is somewhat limited because we don't have all the prescribing information. So anyway, it's out there now. And then we have patient electronic access to health information and public reporting. Objective 9 includes 4 measures, which is the immunization registry. We know it as MICR. A syndromic surveillance reporting. What's that? Well, all that stuff we saw about the prevalence and the incidence of disease. Think about the pandemic. We were checking data sets all the time to find out how much COVID was going on in our communities and our regions and so forth. That's syndromic surveillance reporting. It exists for many things beyond COVID. STIs, mostly around infectious diseases, but also there's some cancer reporting that happens. And then that actually comes into the third one, which is specialized registry reporting. And then measure 4 is the electronic reportable laboratory result reporting, which is ELR. It's just actually it was a front runner in all of EHR, but laboratory values coming across interface dropped immediately into the record. So all of that sort of thing comes into these acts. And then the other one that's mentioned here is macro, which came after high tech, kind of expanded on it on the basis of high tech, but put more specifics into the quality management program for quality, advancing care information, improvement activities, and costs. So all of these incentives, financial incentives, work that because we have an EHR and everything is digitalized, organizations and individual prescribers get profiled as to how you're doing and whether you're meeting these standards and whether this happens. For example, how often do you meet the standard of reconciling medicines at every visit? Well, in my EHR, I have to click something that says, yes, I reconcile these meds. That's pretty basic, and it takes my word for it, but I click it. If I don't, I get a ding. That's all kind of wrapped up into a large scorecard, if you will, and ultimately, although this isn't happening with providers yet, definitely happens with hospitals, changes some of your payment is set aside for these incentives. So in order to get your full possible payment for any encounter, whether that's a discharge or an outpatient visit, ambulatory surgery, an ER visit, whatever, you are going to have your payment adjusted based on your quality score around these things. And that's how high tech and macro have put some teeth into getting us to move to meaningful use of an electronic health record rather than just saying, oh, yes, we have one. The other thing I would tell you is they needed to put some teeth in it because the cost to, for example, a health system, say Ascension or Henry Ford Health System, their cost for their IT infrastructure, the training and all that, the payment of fees to the IT company, whether it's Epic or Cerner or whomever, are enormous. So they had to put a little extra money in the payment, but they didn't want to cover that, to give the organizations enough money to be able to implement this stuff. So the government enhanced some payment, not a lot, but some, to help cover it. But then they put these requirements on it that if you want to get that payment, you got to actually use your IT. So I guess that's the take-home message. So then we talk about consumer informatics and the e-patient. In this chapter, we are limiting the discussion mainly to patient engagement with a healthcare system for the purposes of health promotion and disease prevention. However, patients are also engaging with others besides healthcare providers via social media. Awareness is growing among patients and providers that social media-based peer networks of patients, such as Patients Like Me and CaringBridge, provide valuable information and support for patients with a new or existing disease. 30% of adults report that they are likely to share information about their health on social media sites with others. In this general category of consumer informatics and the e-patient, there's a role and impact of consumer-driven health plans. So the payers get involved in consumer informatics, and their members, the people who they insure, interact with the health plan, providing information and receiving information. But there's difficulty in providing patients with clear cost and quality comparisons. And we have some fairly new legislation, I think you know, in the United States about surprise billing. But billing and cost and quality being presented to the public has been difficult. For it to be meaningful and accurate and to have enough interpretation for the patients to understand what is it they're looking at. It's a developing area, to say the least. And then health promotional research, which could be drawn from a lot of this data, is just starting to emerge. Let's talk a bit about mHealth. This is really a rapidly growing sector. It benefits from patient use of mobile apps. That's the benefit. And there's a lot of challenge with using mHealth apps. Quality is variable. They don't meet any FDA standards. But there are 5 approaches for safe use, and those are educate consumers and health professionals on how to make good decisions when selecting and using mHealth apps. Identify and share potential harms and problems associated with specific apps in a public online forum. Establish a nonprofit independent agency charged with establishing standards and certifying achievement of these standards by individual apps. That, by the way, has not yet happened. Require companies that manufacture and sell mHealth apps to demonstrate a process of active medical review before releasing products to the open market, and require FDA approval. So these are things that have been suggested to improve the quality of mHealth, protect patients, yet give them full access to their data and so forth. These are suggestions at this point. This stuff has not happened. But I believe it will. It's just in development. So that's mHealth, where you're using a company's app that's pulling your data, comparing it to standards and so forth, and offering you some guidance. Say you're diabetic and you want to use an mHealth app for diabetes. You might put in your weight, your anthropomorphic measurements, and your blood sugar today and your calories, and it will calculate things for you and advise you on things to do. That would be a pretty common mHealth app. But there's a separate thing beyond mHealth, just called personal health records, and that is that the patient is owning and in control of their own PHR. They aren't pulling things from a system's PHR like Epic, to keep beating on our old friend Epic, or other sources. They really own it. The main disadvantage is the linkage of tethered PHR to only one specific healthcare provider or system. So usually PHRs would be, say, like, I get my care at University of Michigan. So I'm in mHealth. Sorry, bad use of that word. The Michigan Medicine has a portal. We're probably familiar with portals. They also have other things you can connect to that will pull your data into your app on your phone. So the problem is the app can only pull from one. It doesn't integrate it. So if I get some care at St. Joe's and some care at the U and some care at Henry Ford, which many, many patients do, mix them up. These apps can't deal with that. These personal health record apps don't work well with that. The ideal one would be comprehensive network system that would download and integrate data from multiple sources. So one that has started is this thing called the Blue Button Initiative, and it's on the app there's this insignia you see here with a blue arrow down and so forth. It's a standard symbol on a patient portal that a patient can click and download his or her own EHR securely, but still coming from one portal, one person's system. And this is being trialed at the VA right now. So what are the key points of all this? The discipline of informatics is focused on the use of health information technology to create a society in which all people live long and have healthy lives. Health informatics is both interdisciplinary professional area specialization and a scientific discipline, and that discipline is an integration discipline that integrates health sciences, computer sciences, information science, and analytic sources. Within the health profession of informatics, the scope of practice is defined by the D to W continuum from data to wisdom, and the interactions and interrelationships between the mega concepts or the big concepts inherent in the model, the D to W model. We looked at that earlier. Effective use of informatics tools and techniques by both healthcare consumers and professionals necessitates a high level of digital literacy. So we looked at what is digital literacy. It requires synthesis of basic literacy, computer literacy, information literacy, digital literacy, and health literacy. When considering the health promotion and disease prevention, three factors can be used to determine the scope and organization of the resources of interest. One is the concepts of health promotion and disease prevention, and two, the determinants of health, and three, the concept of the client. The U.S. Census Bureau, which counts every resident every 10 years, is the most important source of population data, and the principal source of health statistics for the United States is maintained by the Centers for Disease Control, CDC. Public health entities require interoperable electronic health information systems to detect, track, and manage illness outbreaks. Interoperable is a key word there, that they can look across many different independent EHRs and pull that data together. Requires standardization and interfaces to be built. Standardization of data elements and interfaces to be built. It is a messy business, to say the least. Patient engagement and consumer engagement includes the actions that an individual takes to obtain the greatest possible benefit from available healthcare services at the most reasonable cost. Engagement requires that the patient requires patients to synthesize robust information, professional advice, and his or her own resources with his or her own personal needs, preferences, and the abilities to promote his or her health by preventing, managing, and curing disease. Full patient engagement requires untethered PHRs to download and integrate comprehensive data from multiple sources, and including primary and specialty healthcare providers, such as health plans, laboratories, and mHealth apps. Now we're moving on to chapter 14, which is about cultural humility. The slide just is the introduction, kind of out of the book, things I pulled off of their text. One thing to look at is in 2010, now it's now 2023. So 13 years ago, the census reported just a little over 33% of the reported race and ethnicity as something other than non-Hispanic white. And that was a 29% increase from the prior 10 years. So if you just keep going at that rate, and we don't, oh, by the way, we don't have the 2020 census data. Do you know why? Because of the pandemic. We just don't have the data yet for 2020, even though it's 2023. But if 2 points and 2 points don't make a trend, but let's say it's going up another 30%, that'd be like 43% of the population. identifies race and ethnicity as something other than non-Hispanic white. Cultural diversity implications for health services and consumers are discussed, and cultural influences the experiences, expressions, the course of care and outcomes of health problems, help seeking strategies, how do they engage, where do they look, and adherence to interventions, all influenced by culture. To mitigate these challenges, clinicians must accurately assess the needs of patients and accommodate diverse worldviews into treatment planning. However, many feel ill-prepared to do so. Despite the efforts to provide cultural sensitivity and cultural competence training in healthcare, in nursing, and other healthcare fields for more than 25 years, the range of cultural differences in each healthcare encounter can make it daunting to address culture in the provider setting. Cultural differences may be rooted in different life experiences, cultural knowledge and identity, social position, social power, differences in language and religion, and a host of other factors. Finally, cultural beliefs, values, and processes influence the provision of care at the system level as well, so it's structural. The ideals and values of the dominant culture are held within the policies, expectations, practices, and procedures of a healthcare system, regulating the problems that are assessed and the ways that social cultural differences are addressed. The point of that statement is the ideals and values of the dominant culture are what's reflected in policies, expectations, practices, and the whole mess. So if you aren't in the dominant culture, if you're on the margin of the dominant culture, you're going to have some trouble getting the care you need and having a fair chance, equity, for outcomes as good as somebody who's in the dominant culture. One can say that culture exists both outside and inside individuals and groups at the same time, which makes understanding the concept of culture elusive. However, it also demonstrates how central culture is to our thinking, our feelings, our motivations, and our behavior. Another domain or dimension of culture is the political and economic patterns of consumption and exchange, wealth and influence, technology, infrastructure, policies, and institutional organization. The political and economic domain of culture includes ways that ideation guides the organization of social structures, including how families, groups, and institutions acquire and distribute resources. The political and economic dimension of culture also includes social control, which is how those in power define, regulate, and enforce what they see as proper conduct and behavior. So, what about culture in healthcare? One of the things we learn from research is even when barriers to access are removed, such as insurance, racial and ethnic minorities still experience a lower quality of health services and are less likely to receive even routine medical procedures. So even when money isn't the issue, or having insurance, or living close to providers, transportation, whatever those things, even when you get rid of that stuff, neutralize it, so to speak, racial and ethnic minorities still experience a lower quality of health services and are less likely to receive even routine medical procedures. The Institute of Medicine, now called the National Academy of Medicine, but Iowa back in 2002, put a report out in 2002, so a long time ago, called Unequal Treatment. And they talked about access issues like language, system expectations, navigation issues, referral patterns, fragmentation services, and other structural barriers to quality, that those needed to be addressed. Patient-level variables, which included the patient's values, hopes and fears, trusts and doubts, beliefs, all about the relevance of interventions. And it recommended culturally relevant interventions and cautions providers to avoid reliance on stereotypes in assessing and planning processes for individuals. So this is kind of a two-edged sword here. You need to be culturally aware. We're going to talk about different levels of that. And at the same time, you have to individualize to the person. So you can't say, oh, you're from Pakistan. Therefore, this is how I should be delivering care to you. No, you have to have an awareness that everybody comes from some cultural basis. And we don't want to take our U.S. Midwestern, urban, semi-urban kind of culture that we live in and just apply everything that would make sense for us to our patients. So it's this kind of balance act of understanding that there's a different cultural background, different cultural view, different cultural values, all that kind of thing, to kind of have our antenna out. But you still have to figure out and individualize what are the patient's attitudes, values, resources, and so forth. So now we kind of go through the movements in healthcare to address diversity. The first one was multiculturalism. Multiculturalism, cultural pluralism, and cultural relativism aim for understanding and unity. Unity, all coming together to be the same thing. The melting pot, so to speak. The concept, the melting pot was pre-multiculturalism, actually, and that was the idea that people come from all over, we all come together, and then we all become the same. That's melting pot. We all melt together, and everybody is changing. There isn't a domination of one imported culture. We form this new culture with all the, characteristics of all the cultures come together. That's melting pot. We knew that didn't work. Moved on to multiculturalism. So the idea that members of different cultures can retain their differences and still live peacefully alongside of each other. From a sociological point, multiculturalism is a national value of tolerance and accommodation. You might call it détente. You do your thing, I'll do my thing, and we'll be accepting of each other. From the minority side, however, there is a growing recognition and frustration that multiculturalism leaves the prevailing imbalance of power unchallenged. So the next one they talk about is Leininger's culture care theory. Now, you may have never heard of Madeline Leininger, but you might know that you have some things in common with her. This is her theory, and a quote right out of the book, which is her quote. I'm not going to read it to you. You can find it in the book. This approach actually has been very successful, and there's been a fair amount of research that proves its utility. And it details the steps for assessing the cultural lifeways relevant to nursing care, but it could be any kind of care. However, this approach focuses on differences between cultures without explicitly addressing issues of power. So Leininger, God bless her, didn't quite get around to power. The culture care theory clearly recognizes that every person is a product of culture and that everyone has culture. However, clarity on the power dynamics and the relationships of the nurse and the patient and of the minority group with the dominant healthcare field simply aren't addressed. Obviously, that's coming up. What are the fun facts? Well, Madeline Leininger has some connections to Madonna University and to Detroit. She was a professor at Wayne State University and a number of other places. Madonna University maintains the archives of her academic work because for some reason Wayne State didn't want to keep them. So we took them, and we have that. And if you want to know where they're located, they used to be in the Deponio building. I believe they are now in the Welcome Center. I've never looked at them, but we have Madeline Leininger's archives of her work. On a personal level, Madeline Leininger and I got our BSNs at the same place, Creighton University, Omaha, Nebraska. She's a Nebraska native. I just was an import for the purpose of getting my accelerated BSN back in 1979. Okay, enough about Madeline Leininger. You know about her. She's a nurse. She's very important in culture. healthcare and culture. Okay, then we get on to intersectionality. We're kind of coming into the current day. Intersectionality and microaggressions. Issues of power and culture critical in understanding healthcare and health. Not going to read the whole slide to you. I'll give you a moment to read it. This is lifted largely out of the book. I pulled in some other stuff here for this one. Issues of power and intercultural relationships have been analyzed from the perspective of intersectionality. That is, the awareness that social categorizations such as class, race, and gender are interconnected, overlapping, and independent systems of advantage, privilege, and power, as well as the source of discrimination or disadvantage. So, this is kind of right in the center of what's going on in the United States right now, not just in healthcare, but all over our culture and our political scene, with people are really drawing lines around this right now. So it probably has some validity. It is touching a nerve with a lot of people, this concept of power and the dominant power and having things structurally built around the preferred cultural aspects and so forth. And you only have to turn on the nightly news. It is just playing out in front of us like crazy right now. Hopefully we'll do some process, come out of this improved. That's our hope. But it is right at the top of everybody's mind. The next movement in healthcare to address diversity is intercultural sensitivity, and that emerged from multiculturalism. This isn't necessarily going in a time linear fashion. I don't know why they organized the chapter that way. I'm following the chapter organization here. But anyway, any cultural sensitivity came out of multiculturalism. And the key to cultural sensitivity was development of intercultural communication skills. It was about how to communicate. Sensitivity of individuals is viewed along a developmental continuum that moves from ethnocentrism, which is I only see my own culture as valid, to cultural relativism, which is I'm open to all kinds of different things. Culture is relative to everything, and it's a more accepting position. The method has a couple problems. It goes on today, intercultural sensitivity. It focuses on the differences rather than acknowledging and helping providers understand that all people are products of culture. So it's kind of like, well, let's talk about Arab Muslims, a big cultural issue in healthcare in the Detroit area. That's a cultural sensitivity, intercultural sensitivity thing. I remember 20 years ago, maybe 15 years ago, having a lady who's a Lebanese woman, a nurse, an Arab, Ms. Bazi, coming to our organization on a broad way and doing lots of training on what it is to be a Muslim Arab in Detroit. I mean, she worked with the Beaumont system. It was then Oakwood. And she's still doing this work, but her approach is also developed over time. So then it was all about, what does it mean? And what are the values? And how do they think? And then somehow the hope was, if we just learn about each other, that would be enough. But it has some drawbacks. And it focuses on the differences rather than acknowledging and helping people understand that all people are products of culture. It assumes the development of cultural sensitivity is logical and progressive. Like first I'm ethnocentric, and then I go through some phases. There is a diagram in the textbook that shows this. And then I emerge as a cultural relativist. And it doesn't examine power critically. So after cultural sensitivity, we go on to cultural competence. And this was all the rage about 10 years ago. Cultural competence emerged as a framework for addressing diversity and inequality in the United States, starting in the 80s, but it really didn't get going until late 2000s. Strategies to improve skills of clinicians, healthcare services, and systems to address ethnic and cultural diversity. And that was a lot. I talked about Mrs. Bazzi and her work, which is ongoing. She's no longer associated with the health system. I think she's an independent consultant. But that was really her approach more than just sensitivity. She was really around cultural competence. So some believe that the literature treats cultures as groups and describes people as members of a culture rather than people who hold or share cultural values. This approach assumes that members of any different cultural group share values, beliefs, or attitudes that influence their behaviors within the clinical encounter, and that those values, behaviors, or traits can be reliably cataloged and predicted. That's not true. We know that's not true. But that is kind of the framework from which this emerges. Cultural competence implied that one knows or has mastered, that is, has become competent about another's culture, and that this knowing can lead to decreased efforts to learn. That's a problem. I mean, if you figure, well, I know what Muslim Arabs are all about, even though I'm, a German white kid from Saginaw, I know what they are. No, you don't. No, you don't. I mean, you could know some things any more than anybody really knows me by looking at me. You probably have a very inaccurate impression of who I really am. And my providers know something about me, but they don't know everything. So, in any event, that's the point. While this is consistent with a multiculturalism perspective, it is inconsistent with the intersectionality approach. This notion gives the provider a false sense of security and promotes the tendency to stereotype groups. It also creates the impossible task of studying many lifeways and cultural traditions and practices represented in our complex healthcare constituency. How would you ever learn them all? I mean, we have a Hmong community in the Detroit area. We never talk about them. They have very specific cultural standards. What about Hasidic Jews? I mean, they exist. We have them. They're here. They're in like New York, but they're here. What do we do about them? When would it end? I mean, my God, how many cultures are there in the world? I don't know. If you have to become expert in every culture that you might ever encounter a patient from, that's an undoable task. So that's one of the problems with cultural competence. And it ignores the effect of power. People have danced around it. It isn't that people didn't know it, they were afraid to talk about it. Why would people be afraid to talk about it? Well, because when we finally did, we see, look at what's going on, woke, to be blunt, the woke versus the anti-woke. I mean, it is completely erupting right in front of our eyes. But that's going on for us as clinicians in our patients. And, we have to put some thoughtfulness about culture in our practice and in our health promotional practice to be relevant and to have any impact at all. So the final one that we have of today, tune in next week for news, is cultural humility. And that is an emerging field that addresses the multi-layered definitions of culture. All providers are on a developmental trajectory with regard to cultural sensitivity and understanding. Power and privilege are critical to address in the healthcare arena, and intersectionality is important in identity formation. Cultural humility is characterized by three factors. The first factor is the lifelong commitment to self-evaluation and self-critique. That's the intersectionality, oh, by the way, if you didn't catch it up till now. It's the reflection, integration. That's what intersectionality is about. The second factor is the earnest desire to learn about power and privilege and to hold the moral position that it is within our scope of practice to interrupt or perhaps repair imbalances where they exist. I would say, in my experience, social workers do this a heck of a lot more than nurses, nurse practitioners, physicians, others. But it is not something that we just expect to be done by the profession of social work. It is all of our jobs if we really want to optimize outcomes. The third factor is the belief that cultural humility is the attitude, knowledge, and skill set necessary to form alliances. It is the attitude that healthcare is a partnership and that partnerships evolve through trust and familiarity. Like any public servant, nurses must therefore assume the stance of being humble, aware that life is full of a great many things to learn. We also adopt a stance of flexibility, knowing that we are very likely going to have to change course as new information reveals itself. Cultural humility takes the position that we don't know what we don't know. That's unconscious incompetence in another model. And when we discover that we are in error, we gracefully stand corrected. Something we could use a lot of right now in the world. So, what's the quality of evidence and recommendations for practice? Reviews generally found moderate evidence of provider access and healthcare utilization outcomes. Unfortunately, evidence that these skills had a direct impact on patient outcomes is fairly weak. No study on cultural competency examined long-term effects, more than a year, and generally found some evidence that interventions to improve cultural competency can improve patient care outcomes. In other words, can't really show that it made a difference in outcomes. This review also found that many studies did not have objective evidence of interventional effectiveness. Cultural humility is a newer approach. In a set of 4 studies, Hook et al. In 2013 demonstrated reliability and construct validity of a client-rated measure of a therapist's cultural humility. They also demonstrated that client perceptions of their therapists or providers cultural humility are positively associated with developing a strong working alliance and were positively associated with improvement in therapy. So that's kind of it. It's not much. We don't have much. But the recommendations for practice are pretty clear. Oh, the other thing I want to tell you is when we see this as these authors report, well, what's the level of evidence, yada, yada, yada. It is as much a critique not of the constructs or the concepts as being valid or invalid. It is at least that half of the issue is we haven't built the research models very well. So we don't actually get good data. It isn't that the ideas are wrong necessarily. It's that the structure of the research methods isn't good enough yet to really know if these things make a difference or if they don't. It's a research question. I just don't want you to, when you read in the book and they put it in every chapter, like what's the level of evidence? What's the strength of the literature? Oh, it's not very good. That doesn't mean the concepts aren't good. It means the research needs to be improved. Okay. So a humble attitude, recommendations for practice. You can't go wrong with that. Seriously, you can't go wrong with that. Stay curious. Don't be a know-it-all. Listen to people. Do what you can. Self-reflection is a realistic and, don't we wish, for all of us, an ongoing self-appraisal. And reflexivity is a term used in research to refer to personal critical analysis of intersectionality. Intersectionality means how's everything coming together, considering all the various relevant data, sources of information about this, internal to us, external to us, policy, all kinds of stuff. How do we critically analyze that? Okay. It is attention to power and privilege in any encounter, whether it be the researcher and their participants or the provider and their patients. Reflexivity focuses attention on the matrix of domination and power. The following focused questions can help the provider understand the client's perception of his or her problems and expectations and desires for healing. What do you call your problem? What name do you give it? This helps you refer to the problem using the client's words and creates an understanding of how the patient views health issue intellectually, socially, and so forth. What do you think caused it? This helps you understand the client thinks caused health issues and begins to reveal it. Why did it start and when? How does your sickness, what does your sickness do to your body? How does it work inside you? This area is called ethnophysiology, and it helps the practitioner understand how the client understands his or her own workings, and so forth. And the list goes on. You can find these, they're actually in the text. Sorry for bumping around there. One of the things you could focus on is the LEARN framework. Pretty simple, pretty standard to our approach to most everything as nurses. Listen first, listen, explain, acknowledge, recommend, and negotiate. You could apply that same framework to things like the health belief model or motivational interviewing. I mean, these all kind of have a familiar ring to them. And then culture-centered interviewing, the questions that I was just talking about, like, what does this mean to you? How do you think you're sick? Those are very important. So these are really on provider to patient interactions. What are we going to do for it? And there is a health promotion that happens between providers and patients. And if you understand how people think about it, that's interesting and it's helpful. But we also got to think, well, how do we ask the community that stuff? Because we may want to change patterns of health behavior that lead to health risks or benefits in a community. So, how do you talk with the community about that? Gets a little murkier because not everybody in the same, we define them in a culture class. They may not actually all believe the same way. But it is interesting. If you want to try this out, rather than saying to people, oh, you have heart failure. How do you think that? Explain to me what you think, ethnographically. What does that mean? How do you think your body's working? That might be a very unusual conversation, and I don't know that you would have time in a clinical encounter to really have it. I mean, it might be a very interesting little project to do. But if you want to have a taste of this, ask people about their diet. How does your diet affect your health? And you have so much to learn. I do all the time. Not just with your diabetics, your hyperlipidemics, the people where you're already zeroing in on diet, people with heart failure, how much salt are you consuming, that kind of thing, people with kidney disease. Those people were pretty standard in our approach. Here's the things we want you to do, and you may come out. But just in your general talking to people, if you have a moment, ask them about their diet and how they think, is it healthy? Is it unhealthy? What is about it? It's just fascinating the way people see diet. And it is certainly individual, but it's also cultural. People have very strong ideas about diet. And it's been enlightening, to say the least. So this slide about cultural humility and healthcare policy. Effective care and services are those that successfully restore an individual to his or her desired health status and help to protect his or her future health. An essential part of ensuring that care and services are effective is to ensure that they are culturally and linguistically appropriate. Cultural and linguistics competency allows providers to navigate the cultural and linguistic factors that affect trust, rapport, communication, and adherence. Equitable care and services are those that apply to individuals and groups regardless of their cultural identity, race, education, health, literacy, age, sexual orientation, ethnicity, religion, physical and mental disability, language, gender expression, gender identity, income, class, and access to care. I think that got them all. Understandable care and services include the clear exchange of information between providers and patients. They assist individuals to comprehend available treatment options and that they need to stay well. Respectful care and services are those that foster an environment in which individuals from diverse backgrounds feel comfortable discussing their needs. The concept of cultural humility is a framework that is consistent with, supports, and enables the manifestation of the CLAS standards in routine practice. I was going to list out the CLAS standards, but I decided that's just a little too deep. We don't need to go there, but if you ever had a curiosity, you can find them. Um, I don't think they put them in the book, but the CLAS standards actually are very helpful. And if you're struggling with anything in your own your group projects at this point related to culture, take a look at the CLAS standards. They're easy to Google. You'll see them there, about 8 of them, I think. Okay, key points, chapter 14. There's an ever-increasing need to address the diversity of beliefs, values, and lifestyles in our healthcare system. Efforts in the 1980s focused on multiculturalism, coming out of the melting pot idea that we'd all merge and become one glob of culture, to we could live in detente and keep our cultural background, to cultural sensitivity, and then to cultural competence, and so forth. But the problem is, you can learn a whole lot about how people live and what their beliefs are and their religion and, social structures, family structures, how, all that junk about all that stuff. Not junk about it. But if you miss the point of power, you aren't getting the big picture. What is it like to be that person from that culture here? What's it like to be here in a person from that culture? That's where the power stuff comes in. We have a history in this country of minorities that are poorly treated. You don't have to really think about it a whole lot. I'm not going to list them all for you, but we got marginalized people. What's it like to be marginalized? What if you're not in the central culture? That's what it's about. What are the barriers, the microaggressions, the stuff people don't mean to be bigots, but they still are bigoted? That's the kind of stuff. We all have biases about abundance things. And so, we're all renewing our nursing licenses. What did we have to have? What did we have to have this year? It isn't pain management. It's implicit bias training. It's all over the place. And it's erupting right now in our political, social environment. Okay. Mandates for healthcare standards were introduced in the 80s that emphasized skill and competency, but they were criticized for creating stereotypes about groups. I think we pretty well beat that up. The relatively new concept of intersectionality helps providers attend to ways that diverse entities such as class, culture, religion overlap to create matrices of power, and helps them consider the broad, diverse identities of both patients and providers and how these influence the healthcare encounter. Cultural humility is an approach that promotes a humble attitude of flexibility and a stance that is always learning about others and emphasizes how culture influences healthcare in general and how power influences the healthcare encounter. With this approach, the provider and the patient are considered partners in a therapeutic alliance that integrates the perspectives and expectations of the provider and the patient into a collaborative treatment plan. Isn't that great? Yeah, it is great. And I'll tell you one thing. If you bring in an awareness and a willingness to address structural societal power issues, go back and look at what Leininger did, because she pretty much defined cultural humility, although she never named it that. That's kind of what she's talking about. That's what they're talking about here. So Leininger is really a great model, and the authors give a nod to it and say, this actually works. Yep, it does. It's about listening and being humble. And I think the other thing about power, I keep talking about it as a political social force, but there is a power gradient between you and patients. Whether you think there is or not, it exists. And even if they react to you in a way that makes you think that they are not particularly respectful of your what you're bringing to the interaction, knowledge, that kind of stuff, they probably are. I mean, people defend against power. They do. And it takes a while to build a therapeutic relationship. At the same time, you need to understand that when we go out with health promotional ideas, there is a back force of skepticism coming against that all the time in the culture. Look at vaccine hesitancy. That's astounding to me, but I'm not in that part of the culture. It makes perfect sense to others. Oh, you can't trust that. Oh, that's not a good idea. Those people are not to be trusted. That is everywhere. So, cultural humility is understanding, don't stereotype, be aware that there are tons of different things out there. And my solution as a provider is to just try to build a personal one-on-one relationship so that some of those barriers to communication can be lessened. And to end my sermonette, I would just tell you, this is just my own words. We are best positioned profession, nurses, to bring anthropology, sociology, and politics together with health science to improve health outcomes of our increasingly diverse population because our knowledge is already drawn equally from social as well as the physiological, medical / health sciences. We've been doing that from, oh my God, the 50s with biopsychosocial nursing. Henderson, we started doing it then, where we diverged from being kind of nurses were kind of like, quote, little doctors, you know, I mean, like we knew a little bit about what physicians knew. That was kind of where we were in the 40s and 50s. Lots of technical knowledge. Then we got Henderson with biopsychosocial nursing, and we built on it from there. We are light years ahead of other professions in this regard. I think we don't recognize that necessarily. So my point is, if anybody's going to help with this stuff, we need to be at the forefront because we are the best prepared. And not to mention, we are the most ethnically diverse healthcare workforce in the United States. So, sorry this went so long. Hope you were able to stay with it.